Hello, and welcome to the virtual learning series titled Learning Together, Emergency Shelters and Substance Use Facilities. Please note this session is being recorded. We are pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French from the bottom of the interpretation menu at the bottom of your screen. If you need support at any time during the discussion forum, you can reach out to one of our producers using the chat feature. My name is Lindsay Yarrow, and as the Senior Improvement Lead on this program, I'm so excited to be joining you today as the co-host for today's discussion forum. I'd like to start by acknowledging that we are meeting on land that has been inhabited by Indigenous peoples since the beginning. In particular, I acknowledge that I'm joining you today from Kingston, Ontario, which is the traditional and unceded territory of the Haudenosaunee and Anishinaabe peoples. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. At Healthcare Excellence Canada, we continue on our learning journey and commitment to support improvement with and for all people in Canada. Healthcare Excellence Canada is an organization with a relentless focus on improving healthcare with and for all people in Canada. Launched in March 2021 from the amalgamation of the Canadian Patient Safety Institute and the Canadian Foundation for Healthcare Improvement, Healthcare Excellence Canada has a greater capacity to support partners, turn proven innovations into widespread and lasting improvement in patient safety and all the dimensions of healthcare excellence. We believe in the power of people and evidence and know that by connecting them, we can achieve the best healthcare in the world. Healthcare Excellence Canada is an independent, not-for-profit charity funded primarily by Health Canada. We're pleased to share that this program is delivered in partnership with the Canadian Centre on Substance Use and Addiction and the BC Patient Safety and Quality Council. Today, I'm joined by my co-host, Ryan McCarthy. Ryan, I'm going to hand it over to you for an introduction.
Thank you, Lindsay, and hello, everyone. My name is Ryan McCarthy, and I'm the Director of Knowledge Mobilization with the Canadian Centre on Substance Use and Addiction, and it's a pleasure to be here with you today. I'd like to take this opportunity to introduce our speakers for today's events. Nicolia Lukic from the Champlain Centre for Healthcare Ethics, the Ottawa Hospital. Jeff Carabano from the Social Work Community Clinic at Dalhousie University, and Eric Johnson from the Navigator Street Outreach Program. I will hand over our virtual mic to you so that you can introduce yourselves. Please turn on your cameras, and I will first turn it over to Nicolia.
Thanks, Ryan. So my name is Nicolia Lukic. As Ryan mentioned, I am one of the regional ethicists at the Champlain Centre for Healthcare Ethics. And we operate out of the Ottawa Hospital, but provide ethics services to everyone in our Champlain region of Ontario. So all of the hospitals, long-term care homes, community health centers, home care providers, and mental health and addictions bodies.
Great, thanks. Eric?
Oh yes, as he said, my name is Eric Johnson, and I work as the street navigator for the Navigator Street Outreach Program here in Halifax. And so I work on the ground with people where they're at, usually in encampments or in different sleeping arrangements that they have, and I just try to help them out with whatever they want to do. So I talk to a lot of people every day, and I kind of have a good perspective sometimes on what's going on in Halifax here.
Thank you, Eric. And Jeff?
Hi, welcome everybody. It's an honor to be here. My name is Jeff Carabano. I'm a professor at Dalhousie University, one of the co-founders of Out of the Cold Emergency Winter Shelter in Halifax, Nova Scotia, and one of the directors of the Dow Community Social Work Clinic.
Great, thank you. And I will turn it over to our speakers.
Okay. So today's webinar is going to be focusing on some of the ethical challenges having to do with COVID-19 vaccinations. And I recognize that there are a lot of ethical questions and concerns with vaccines, and we've narrowed it down to a few that have come up in our work. There will be time at the end for discussion during the unrecorded part of the webinar. So we'll go through the slides, and you can always save your questions for the end. So the objectives for today's session are we're going to describe the pandemic, or the decision-making, during the pandemic, and explore the balance of ethical principles that collectively we have had to overcome. We'll also consider the use of a framework for ethical decision-making, just very quickly, just for your reference. and then explore examples of some of the difficult ethical decisions during the vaccination process that we've experienced. And as I mentioned at the end, we'll discuss further challenges and solutions with all of you to try and bounce some ideas off of each other. Okay, so during the pandemic, our decision-making from an ethics perspective had to change a little bit. Prior to COVID-19, the healthcare system in Canada and our corresponding ethics frameworks really emphasized patient autonomy. So we all have the right to make our own decisions. We really encouraged individuals to make a choice based on their beliefs, their values, as opposed to going with, whatever healthcare suggested. And so the legislation also reflected that. So in Ontario, for example, we have the Healthcare Consent Act, which instructs providers that patients and their substitute decision makers in some situations should be acting in accordance to their own values and beliefs. And as a provider, we're to respect those choices, even if we disagree with them. But when the pandemic started, we had to shift our values a little bit, and we had to think about the greater good, which we do in some cases in public health, but we really had to shift as an entire healthcare system. And the reason we did this was to sustain resources. So personal protective equipment right at the beginning when there were shortages. In a hospital setting, we had to think about ICU beds and ventilators, for example. Staffing also became a resource that we had to think about. How do we keep our staff safe in order to keep our facilities running so that they're not at home sick? We also did it to flatten the curve. So those public health measures like wearing a mask and physical distancing to try and bring the numbers down. And ultimately, and we're still in this, we want to save as many lives as we possibly can. And there was more of an emphasis on how do we collectively achieve this goal as opposed to just focusing on one individual. So I apologize for sort of the busyness of this slide, but it shows the shift. So on the left-hand side, it shows how we had to balance more utilitarian schools of thought. So from an ethics perspective, the theory of utilitarianism or consequentialism really emphasizes, again, doing the action that brings about the greatest good for the greatest number. And so we've seen that shift. And in the graphic, on the left-hand side, we have the heading of principalism, which is what most of our healthcare is what we call most of our healthcare systems focus on what we call principalism, which is that focus on autonomy and patient-centered care. Now, in the context of vaccines, we're still thinking about the greater good, but we also have to recognize that having a vaccination is an individual choice, and it does continue to be an individual choice. We can't force people to receive a vaccine if they don't want one. And so in order to try and promote that autonomy, we had to shift back, right? Shifting back to empower individuals to try and reduce barriers to accessing vaccines, because there's definitely barriers in terms of, can a person get to a clinic? Do they understand the information about it? And really, again, going back to everyone does decide for themselves. And we can emphasize that, by getting a vaccine, you're helping yourself, but you're also helping others. But ultimately, that decision is an autonomous one. Okay, so these are just some principles, and there's 2 slides of ethics principles, and I won't spend a lot of time on these, but when we're making difficult decisions, especially from a pandemic perspective, these are the principles that we may want to consider that help us justify the choices that we're making. So we have beneficence, which basically translates to providing benefit or doing good. We want to try and maintain the highest quality of safe and effective care within resource constraints or other constraints. We have solidarity. So we want to build, preserve, and strengthen interprofessional, interinstitutional, and intersectorial, as well as interprovincial and territorial collaborations and partnerships. So we've seen the benefit of working together, whether it's in the same sector or within the same province, to try and make good decisions that impact the communities we serve well. We have reciprocity, so supporting healthcare workers who are or may be exposed to COVID-19, mitigate any potential harms or risk that may cause. So we recognize the work of the frontline staff. We want to make sure that they feel safe. And then we have utility. So this is where that pandemic decision-making comes in. So while considering all of the other principles we'll talk about, we still have to think about maximizing the greatest possible good for the greatest number of individuals in some circumstances. And then furthermore, we have equity. So promoting just and fair access to resources and services. And we've seen a lot of vulnerable populations during this pandemic. We've seen inequities grow. They were already present, but the pandemic has really shone a light on, some of this access that, we maybe pushed aside a little bit or didn't really think about, and it really is prevalent. And we can see that, it's becoming a further issue. We have stewardship. How do we effectively, carefully, responsibly, use available resources as best as we can? And then we have proportionality. So this is less so about vaccination, but also thinking about, is our response to harm bringing about greater harm, for example? Is it proportional? So if the risk is low and our response, for example, is, really restrictive, that's not necessarily proportional, and vice versa if the risk is really high and we're not doing enough. So this is where especially in management, we have to think about, is what we're doing proportional to the risk that is actually present? And the last principle I wanted to point out is trust. So we see this in healthcare, especially with vulnerable populations with substance use and in homeless shelters. We want to foster and maintain public, patient, and healthcare provider confidence in the decision-making process, which is difficult to foster. I'm sure we've seen this with government, that if it's not a transparent process, we may not trust in the choice that's being made or why. So this piece is especially in the healthcare context, when we want to try and promote vaccination and we want to try and promote well-being, it's really important to foster that trust. Okay, so I just very quickly want to point out that there are frameworks and tools available. So if you or your team is in a situation where you have to make a difficult decision that has an ethical piece to it, it can be helpful to use what's known as an ethical decision-making framework. And there's many that are out there. You may already have one within your organization. This is one, and it's 2 slides that we use sometimes. It's called the IDEA framework, and it's a 4-step process. It's an acronym, IDEA. And it really guides you through difficult decision-making to find a solution at the end. And it's probably already how you make decisions, but actually documenting that you've used an ethics framework can help justify the choice that you're making. So I'll very quickly go through it. It's in the slides. And if you have any questions, you can definitely contact me afterwards. But step 1, you identify the facts. So you have an ethical dilemma, you have a choice to make, you understand what information do we know, what information do we need to find out, who do we need to speak to. If it's a patient situation or a client situation specifically, you want to talk to them and include them. If it's a decision that affects frontline staff, you might want to talk to them as well. You gather information, you move on to step 2 to determine the ethical principles in conflict. So why is it an ethical principle? So there's 4 listed there. They've got the whole list that I just presented as well. And so you determine, which principles are in conflict. So, it may be somebody's autonomous right to make a certain choice, but it could put other people at risk. So we have autonomy and what we call non-maleficence, or doing no harm. So when those are in conflict, those are in that scenario, those are the ones that we want to focus on. And then the next slide moves on to step 3, which is to explore the options. So we've analyzed, we've gathered information. What can we actually do about something? We brainstorm, 2 to 3 to 4 different options. We consider the positive outcomes, the negative outcomes potentially of each one. We think about whether they satisfy the ethical principles that we've determined to be in conflict. And we want to make sure that the options comply with any corporate policy, regulations, or the law. Then we move on to the last step, step 4, act and evaluate. We pick an option, we develop an action plan, we document it in a patient's chart or document it globally as an organization, and we see what happens. And it's important that if you're dealing with these really challenging scenarios and you've taken the time to use an ethics framework or go through it as a team, you want to make sure you come back and evaluate the plan, the decision, see what went well, see what didn't go right, and do a self-evaluation. So that's just one example of something that is, a tool that you could use. Like I said, there's many other ethics frameworks that follow the same process, I guess, and that achieve different goals. Okay, So now that that sort of ethics piece is done, so we've identified some examples of ethical issues with vaccination in this particular population. And so we'll talk about, I think there's 4 of them, and Eric and Jeff will jump in, and then, you know, we're definitely willing to take questions and have a discussion openly with everyone else. Okay, so the first ethical issue that I've encountered is, how do we obtain informed consent? So in order to receive a vaccine, all of us have to, you know, sign a consent form, understand potential side effects, you know, what does it actually mean? And from an ethics perspective, we're thinking about autonomy. So this is how we exercise our autonomy in healthcare, where we can provide consent or not, you know, if we don't want to do something. It thinks about justice, making sure that what we're doing is fair. So it's not just, you know, physicians or organizations making decisions for you. And it's also thinking about equity. So some of the questions that we identified, the requirements may be difficult to meet. So in Ontario, at least, informed consent, a patient or a client, an individual has to be capable of making a decision. And especially in a substance use population or a homeless population, what does this really look like? If somebody's confused, is it capable at the moment? Is it capable over time? And also, who is assessing capacity? So traditionally, in a hospital setting, it's a physician who has skills to do that. But you know, is it a nurse? Is it, you know, a frontline staff member that knows the client or the individual? And do they feel comfortable saying, yes, you are capable, or no, you are not? And in the situations where somebody may be incapable of understanding or appreciating what a vaccine really means, you know, do we need to involve a substitute decision maker? And what happens if we can't? So in Ontario, at least, and I can speak for myself, maybe Jeff and Eric can speak about Nova Scotia's system, it can be difficult for the homeless, you know, population to have a substitute decision maker. And, you know, the public guardian and trustee, which is our sort of government piece to that, can be difficult to reach, or they may not feel comfortable making a decision that's, you know, not urgent. So that piece can be tricky. And then we think about information. Is the individual properly informed? Do they have the right information? Has misinformation been spread that we need to address? So we all know that there's misinformation out there. People speak to each other. Experiences are shared. Some people believe in conspiracy theories. So making sure that people have the right information if they're able to comprehend. So we also then have informed refusal. So I mentioned that, you know, consent, we can consent, but we can also refuse. And we all have our own reasons for maybe refusing. But should we question those who decline a vaccine? Do we need to investigate, why don't you want a vaccine? Is it a legitimate reason? Do you understand? Or does somebody just not want one? So there's some pieces there about how far do we probe? And then consent versus assent. So if we're questioning those who refuse, are we questioning those who show up, who sit down, who say, yep, but maybe they're not really aware, right? So they may not be giving consent, but by them sitting there, they're just agreeing to receive the vaccine. And do we need to question those individuals as well? Or do we want to think about it from a perspective of, well, they're getting a vaccine, so that's good enough? So Jeff and Eric, I don't know if you have anything to jump in, to add for this particular issue.
Yeah, I think we could talk about this. This is a really pertinent one, because I feel like it's something that I come into, that I think about almost every day, of just like even just getting people to sign paperwork or sign consent forms when their baseline is probably what is they legally cannot consent, if they're always under the influence, or if their mental health and just what's going on in their own head is preventing them from, is putting them in a bad way, that they probably don't have all the same facilities to consent to these things that the rest of us would have. But that's why I think we have frontline workers, and we have people who know the population. We have colleagues and other people around that might be able to kind of support or deny those services to people, which, it's one of those things that I don't think we can make those decisions for people in a vacuum. We have to take other people's and other, and talk to your colleagues and get other people's opinions on it too, because you might know one thing about this person, but somebody else might know another one. So these are all really good things to talk about. And there's no real quick, hard answer that is the right and the wrong way. It's very, very subjective.
Yeah, absolutely.
Yeah, hi. Yeah, I mean, these are massive ethical conundrums, right? This is why they fit under, these ethical challenges that are posed in very complicated scenarios. And I think you've highlighted some very, very key pieces. And I think the best that community sectors like shelters, drop-in centers, health clinics can be doing here is kind of how Eric noted, is having as much information and familiarity with the population, having deep trust, having deep understanding of the individual so that you can share as best as we can pertinent information, have space for discussion, have space for counter arguments as well. Our clinic kind of seemed to, we started to become kind of a space where people would phone and ask our opinion about what they should be doing here. And I think, I did, I'm part of a group that's done a kind of a social science humanities research council research study on kind of the homeless sector and COVID. And we were interviewing people experiencing homelessness in midwinter when there really wasn't a good sense of how the rollout would look around vaccines. And the vast majority, we had around 55, 60 individuals that we spoke to. The vast majority noted that they had very little information. They did not know what it was about. And I think that's the starting point is, and this is not just for the homeless population, this is for everyone, right? Is sharing key health information and also doing it through particular means where there could be enhanced trust. And I know we'll talk a little bit about that, but like having individuals that particular populations trust very much. And one is kind of, a peer kind of aspect where you have folks that are kind of community leaders in the homeless population that can also be speaking to those dynamics.
Yeah, really great points. And it all speaks to that informed piece, right? That information. Another sort of piece that came out of this was the legal versus the ethical. So legally, we need consent forms, like Eric said, and trying to jump through those hoops. But ethically, if a frontline staff member can vouch and say, no, this person's level of baseline capacity is here and we felt comfortable with that, it's going to maybe look different from, an independent person who's just looking to check the boxes. So I really think, to Eric's point and to Jeff's point as well, it's very subjective. And the frontline staff are really who we should be relying on here. Okay, so we'll go on to the next ethical issue, which is related, about second dose uncertainties. So for the Pfizer vaccine, for the Moderna, for AstraZeneca, they all require 2 doses spaced apart, right? And so from an ethics perspective, we're thinking about beneficence, so providing good. We know it's better to have both doses of the vaccine. It's better protection. We're still dealing with autonomy and that people have those choices. And then utility. So are we using our resources, are we benefiting the greater good? So one interesting piece with this population is that they're very mobile. So they're not always in one place at the same time. They don't have a permanent resident that they're, residents that where they're always, we can always find them. They always come back. So there's a risk that they may not be available to get their second dose, or we can't reach them to get their second dose, or they don't remember to come back for their second dose. And so some of the discussions that I've had with some of our shelter partners, is having a first dose good enough? Right? We know that there's protection with just having one dose. Should we, really be making a lot of effort to find these individuals or to try and convince people to get another dose, for example. And so, I mean, this is a less, from my perspective, a less complex issue where somebody has one dose, it's still some protection. But it's a question of, how hard are we going to try to get people into second doses? How are we going to monitor that? And the other piece that we know is that the second dose, at least of Pfizer, and I can speak for myself, there are sometimes symptoms that you experience, like a fever, like achiness, like colds, that individuals experience on a daily basis, but we can expect it with the second dose typically. And so do we have resources available for these, for substance users or for homeless individuals in shelters that can help with those symptoms? And, is that piece going to affect somebody's wish to get a second dose if we know or we expect them to feel sick afterwards? So we'll just go back one more. So we'll just see if Jeff and Eric have anything to add on the second dose uncertainty.
I don't know. Maybe it's because Halifax is a smaller city. This hasn't been, as far as I can tell, this isn't a huge issue because we seem to have a good idea of where people are at. I've definitely spent a lot of time when I get a text from one of the MOSH nurses saying hey, this person's due for their second dose. Can you please try and track them down? And I will just put the word out and try it. And sometimes we find them, sometimes they get found on their own. I've put a bit of time into it, but it's not a huge deal for us because it seems like, Halifax being not huge, that there's, a couple hundred homeless people and we can keep track of most of them pretty well. I'm sure there's a number of people that have missed out on that, but it seems to be working pretty well here. So I don't really know if I'm the best person to ask there.
Yeah, I kind of echo Eric there. Also, I think there are creative ways to reconnect with folks. A bunch of us did a study a few years ago with young people on the streets in Toronto and Halifax, and it was a longitudinal study, and we need to connect with folks once a month. And there's ways, through kind of outreach workers like Eric, also asking folks who is somebody that they could contact if we can't find them on the initial interaction, ways that we can remind folks by posting, knowing, like Eric says, knowing where people are is very, very helpful. A lot of people have phones now, so having reminders via text or particular apps have proven to be successful. So I think that those issues, again, haven't been as significant. Feeling fluish and somewhat nauseous after the second shot. I mean, being homeless, you're consistently feeling like shit. Which brings up the larger question of the ethics of actually being homeless. Nicolia, the framework that you've used around core characteristics of ethical analysis can all play into, a larger argument around the ethics of actually how can we be allowing folks to be living on the streets. The notions of equity, justice, beneficence play deeply into, questioning, why we cannot be providing housing as a human right. And then the last point I'd raise is, I think, where we are seeing kind of a real ethical messiness is around kind of folks that have deep trigger effects by any type of injection. And I think that is something that I really just don't know how we can kind of get around that.
Yeah. And maybe in the discussion, if anyone has experience with that, can jump in. I know that for us in Ontario, in Ottawa, where I work, the homeless population is a little bit larger. And what was difficult was that 4-month interval originally between vaccine doses. And so that was a significant amount of time. Obviously, we've been able to shorten that a little bit, but this is less of an issue. I will recognize that, to Eric's point. It's not the top of the top, but it did come up. So I thought I would bring it up in case anyone later as well has any questions, concerns, or things to share. Okay, so we'll move on to the third ethical issue is the incentive for vaccinations. So the issue or the question has been brought up of, how should we or can we incentivize this particular population to receive a vaccine? So from an ethics perspective, again, we're thinking about benefit to both the individual and the greater good. Transparency comes up as well about what we're giving an incentive for, what the incentive is, why we're doing it. It questions maybe autonomy. So is somebody really making their own choice, or is it maybe coercive? And then equity as well. So the question really is, can you provide either an incentive or a reward to get somebody vaccinated? So one example that came up in Ottawa was if you get a vaccine, you get 1 gram of cannabis, which we can provide them with. It's usually $4 on the street. So it's not a huge kind of reward, but it is, a respective thank you from their perspective. One nuance to it was, should you disclose that there is a reward before the entire process begins? So before the consent form is signed, to say, okay, if you get a vaccine, if you sign this form, you'll get a reward. Or do you just offer it afterwards and say, okay, we've gone through the process and, surprise, there's a reward at the end. And then another question is it coercive? So are we coercing people into doing it? Or is it just a simple thank you? And one of the perspectives from the homeless shelters that we work with, is that this is a sign of respect for this particular population. It's providing something to make their lives a little bit easier, a little bit better, because they may not have quite the same buy-in, as those who are not homeless will have in terms of thinking about the greater good. And we already know that this happens, for example, if individuals take part in surveys, if they talk to the media, if they're part of focus groups, they do get a little bit of a reward. And we're not talking about like a new car or something like that. It's something it's significant, but it's not completely significant. So these are some of the questions that, at least in Ottawa, have come up in terms of how do we support this population and provide them with a little bit of a thank you, but there is some pushback as well. So I'm curious, Eric and Jeff, if you've had experience with incentives, either for vaccination or you could equate it to something else, or your feelings and perspectives on it.
I, for decades now, have been fighting Dell ethics around when I do research with different populations around being able to provide honorariums. And so from a research perspective, this happens all the time. And it's a way to thank folks for their expertise, for their time, just like, if we were going to engage anybody around their insights, that we would be able to find ways to thank them. So I don't see this as a big issue. I mean, we see it in civil society, right? We see it in the States big time. There's lotteries around getting people to go get vaccinated. I don't think I'm one to kind of argue what would be the right kind of thank you piece for this. And I think, again, that would maybe be best left up to kind of peer groups to decide what would be ways that we can thank folks for taking time out of their survival to go and get a vaccine that is going to be, for that universalistic analysis of any type of public health rollout that's going to help everybody, that we find ways that, possibly we could be thanking everybody for doing this. I know my youngest swabs at a pop-up testing site here, and it's amazing just how much they are thankful to anybody who comes in to get tested, like just the warmth in that piece. And I think any type of thanking folks for doing this is important. And I was going to say one other thing. And also, the incentives can also be, we know it's very well documented, the problematic relationships and tense relationships that marginal populations have with formal health systems. So in that, we know that homeless populations are kind of deeply underserved by health systems and are suffering from emotional, physical, psychological wellness issues. So, possibly some of those incentives, to enter into a system that they trust. So, for example, community outreach programs out here in Halifax and or Nova Scotia, we have a mobile health unit that's very well respected by a lot of the homeless communities, is to be able to allow this type of intervention, this vaccine, to also maybe be incentivized by providing, just a larger kind of overall health checkup, or to update other vaccines that folks need. So it can be shaped around this sense of building, a kind of more caring, compassionate connection with health systems and this population, as opposed to just this kind of transactional engagement.
Yeah, and my first reaction to reading that was just only a gram. Like, I feel like people should get more than that. But also for me, just a kind of aside, is that we do every 6 months or so, we try to do a census of the population of people who are homeless here. And the last time we did it, we offered people either $25 gift card or $20 in cash for their times. It takes, 10 or 15 minutes to fill it out. And I think 95% of people just took the $20 cash because people just want to make their own decisions with it. So anytime we offer people incentives, I always encourage it to be cash, like kind of like Jeff was saying, like, yeah, we can give out weed or booze or gift cards or food or something like that. But really, people will just often sell that for a lesser value to get what they actually want. So I always encourage people to give cash because, respect people's autonomy. If we're going to go back to those things, if you're going to just give them weed, maybe they don't want to smoke it, right? Maybe they just give it to their friend. But if you give them cash, they can still give that to their friend too if they want to. Or they can go buy food, or they can go buy a beer or something with it. So I like to just give people the autonomy to choose whatever they want to do with it, because it is their time. I'm getting paid for this. I hope most people who are injecting the vaccines are getting paid for it. So why aren't we paying the people who are getting the vaccine? Especially when it comes to when we saw at the beginning of the pandemic, when there was a few op-eds and a couple news stories going about how homeless people could potentially be spreading the disease. And so that's why we should put them in hotels, and that's why we should support them. And it's like, okay, so back then you housed them because it was for the greater good of society. But now when it comes to vaccine, shouldn't we also be rewarding them if it's for the greater good of society? Like, they're doing their part just like anybody else. And after they've been forgotten so long, like, I think we should be giving them compensation for this. Because they've been forgotten and neglected by mainstream society for so long. Like, they deserve anything they can get.
Yeah, absolutely. And I think that's a good point, right? Thinking about what is that actual reward? Is it equitable, right? Because maybe not everyone will want cannabis or a gift card. And to your point, you could have something that's universal that everyone can agree upon. I know that our shelters in Ottawa have had a lot of outbreaks, and they've been subjected to a lot of testing. And I mean, it's a lot, and people are tired. And I mean, I wouldn't want to get tested that frequently. And so it's thinking about what if we put this population through just in the pandemic, but also, to your point, in general, right? Because they're all already marginalized. And so something like an incentive or a reward is not something new. Like Jeff said, we've been doing it for a lot of things. It's just kind of, it's that sign of respect, I would say, which I think both of you have agreed on. Okay, and then we'll get to the end all be all of the ethical issues is the relationship with the healthcare system. So Jeff, you brought this up. This is the big one, right? And this sort of speaks to that bigger ethical issue. And there's many that I, as an ethicist, can't solve on my own, but we're trying to be as supportive as we can. So we're thinking about trust, we're thinking about transparency and equity and honesty. So we recognize, and both Jeff and Eric have mentioned this, that a lot of the individuals who are in this population have had either a negative experience with the healthcare system, or they just, they don't trust public health units, they don't trust outside, healthcare coming in. And so they may not trust information about vaccines. And there may be a perception that they're being taken advantage of. So, how do we address that piece specifically about vaccines, but also recognizing this greater challenge of just general interaction with healthcare. And this also, so this definitely applies to the individuals, the clients that we serve, but it also applies to staff. So we've also seen that, some staff may not be trustworthy of the vaccine or of public health units, for example, if they've had a bad experience through this pandemic. And so how does that get transferred to the clients if the client or the individual is asking a frontline staff member, should I get vaccinated? And you want to be honest with them. So thinking about that piece as well. One other suggestion that came up, so this is less of an issue now, but at the beginning when we were rolling out vaccines and we were prioritizing certain groups over others who are more at risk, for example, there was a question about, is publicly vaccinating a manager or somebody higher up promoting solidarity? So, let's say, I don't know, the CEO of an organization, of a large organization, who would not be eligible because they're not patient facing, they're not at risk in terms of who they interact with, they work at home. So if they get vaccinated and everyone sees that, well, I'm going to get the same vaccine as them, and surely we're not going to, I don't know, poison them, give them something that's inappropriate, that may actually increase vaccinations. So we kind of said, okay, maybe ethical to actually do that. But in terms of just generally, how do we build trust? And Eric and Jeff have also talked about some of these solutions and also strategies, repeated visits with trusted staff and volunteers to disseminate information. So it can't just be a one-time thing. That conversation has to continue. It has to be with somebody like Eric, who's on the streets, who has interactions with these individuals, who has a rapport, and there's a trusting relationship there, that it's honest. And then also thinking about location. So, can we actually go to the shelter and give the vaccine, as opposed to asking people to go to a clinic or to go to somewhere where they don't feel comfortable or they do feel judged? Can we make it as accessible and easy for them to feel comfortable, make it a good environment, have those rewards, to try and, some of those fears of getting a vaccine somewhere else may be contributing to why somebody doesn't want to get a vaccine. So this is a snapshot. There are many more questions that we could ask from the relationship piece and the trust piece as well. So Jeff and Eric, you guys are more on the ground than I am. So you can, feel free to jump in anything that we haven't already talked about. But this is kind of, I think, what's really at the core of some of the ethical concerns.
That's a tricky one. In Halifax, for homeless service providers, there was a special date in the beginning of April, I think, when all of us who work frontline were supposed to go get our jabs. But it was at a shelter that I don't spend a lot of time at. That it was in the North End, so it's not really my kind of community. And it was all service providers at once. And so I talked to the people out of the cold, and they're like, "Oh no, well, we're going to get ours next week." And it's great because all the staff and all the clients are going to get them at once. And so I decided to get mine then. And it was just one person, but when I was walking down to go get my vaccine, I was like, "Hey man," talking to one of the guys that I know on the streets. And I was like, I'm going to go get my vaccine. You want to come? And he's like, "Oh, I don't know." But then I just kind of, through force of personality, was able to just be like, "All right, I'm going to get mine. Like, if you want to come and watch, or you want to see me do it first." And I was able to get one person vaccinated that was maybe vaccine hesitant, but that was more of that kind of personal kind of trust, maybe, not to, inflate my own ego too much. But I think that helps when you have those people. And I don't know. I remember when I worked at shelters before, most clients had no idea who the shelter manager was and who like the executive director was. So I don't know if that would be useful or not, because they're usually so far removed from those things. I guess it depends on how hands-on and how well known the managers are to the people who you want to get vaccinated. Because yeah, like it could be like a great executive director who's still awesome at their job, but they don't spend 8 hours a day, 12 hours a day on the front line of the shelter or walking around talking to people. So it might not have any effect at all. Just like if the mayor got vaccinated, I don't think that would encourage a lot of homeless people to get vaccinated, because nobody cares, honestly.
Yeah, absolutely. I think that the piece that I was trying to make was like to get staff to buy in, because some staff may be hesitant. But I think, but it could be anyone, right? So if it's you and the homeless, people that you interact with see you exactly like you said, even if it's just one or two people, they may be more trusting of it because they know who you are.
Yeah, that definitely helps then.
Yeah, absolutely. And I think also just being able to have, either kind of vaccine clinics that are in these communities where folks feel safe. They are familiar with the faces around, and they can be able to, yeah, kind of speak to folks and see, if there is hesitancy to be able to um, kind of be in worlds that they're familiar with. I know right now in Halifax, they're like the shelters are trying to have these clinics return to these communities for those who are new into this in the shelter world or the street world, who have not been vaccinated, who wanted more time to think it through so that they don't have to actually, navigate more formal systems, which would be impossible, right? For the vast majority. And I think I just popped in my head right now around I think, the paperwork piece of people going in. There's folks that are experiencing homelessness that don't want to be sharing their real names, their real ages. So to be able to allow folks to use their street names, not provide aid, especially for younger populations, I think is quite significant here as well.
And that speaks to that kind of like legal versus ethical piece of the consent process, where exactly like you're saying, it may be the barrier that, seems like it could be addressed, as opposed to some of the more significant barriers there. Okay, so that's the end of our examples that we came up with. I'm sure there's many more. Before we move on, just quickly, Jeff and Eric, is there anything else you wanted to add before we open it up for discussion? No, Eric says no.
I think I'm good.
Perfect. Okay, so I'll hand it back over to Ryan then.
Great. Thank you, Nicolia, Jeff, and Eric. What a fascinating topic. We will now move into the discussion portion of today's event. If you would like to provide comments or ask a question, please raise your hand under the reactions menu, and our team will invite you to unmute yourself when it's your turn. For those who would feel more comfortable adding their comments and questions in the chat box, please feel free to use this approach as well. I'll invite everyone to now turn on your cameras if you would like. Please note that we are now ending the recording of this event.